everybody. If we start with medical research conduct around the Arab world, actually the situation is very embarrassing. We produce only 1.6% of the whole world output of medical literature. And if we compare that to Turkey, which is a neighboring country, they produce 1,300 by 1 million, but Arab countries produce in the average 189. If we focus more on Syria, Syria actually is among the lowest Arab countries in medical research production. We produce only about 39 papers per 1 million in comparison to Lebanon, which is also a neighboring country, and they produce 750 papers per 1 million, although the population in Syria is 5 times the population in Lebanon. So there is a huge gap in medical research in Syria, and if we want to investigate that, we can see that several cross-sectional studies has been conducted on medical students on different educational levels. However, we do not have any study that focused on medical residents and postgraduate dentists and pharmacists. And we think those are the most important contributors to research making, because they are required to conduct research projects for their graduation. So about 2,000 of them conduct research projects every year, and those are wasted efforts if they are not published. They are also in direct contact with patients, and they work usually in large university-affiliated hospitals. So the patient's flow is very high in their centers. We aim to assess their attitudes, barriers, and practices to suggest solutions, evidence-based solutions. We have 8 universities, but we focus only on the universities that has higher educational programs for medical and paramedical fields. And we also included the Syrian Virtual University, which has a medical education program. Our study was conducted in July 2020, and actually we didn't focus on all the postgraduates because we wanted to focus on a fraction of those who are the most important. And we thought that if we focus only on the year that are required to prepare and plan for their projects, that would be the most effective way. And we used the adjusted questionnaire, an adjusted questionnaire from a previous study we conducted on medical students. First, for the demographics and representativity, we think that we have very high representativity rate. We have about a fifth of the whole 2,000 students in these programs. And this also works for all the categories regarding university and specialties. But for medical education and surgical specialties, we have a little bit lower representativity rates. For the attitudes, we have very high attitudes among those students regarding medical research. They think that this medical research is important and their participation is also important, and they think that there should be part of the curriculum that trains them on medical research, and about 60% think that research will be part of their long-term career goals. When we talk about barriers, of course, there are a lot of barriers, but surprisingly, the most important barriers were the training program. They do not have enough effective training for medical research, or at least they do not have a practical education for that. Followed by the lack of opportunity and the lack of supervision and the unavailability of mentors, and later comes language barriers and lack of time. So when we ask them about their previous participation in research and submission, less than 30% of them participated in a research project before, and less than 13% of them tried to submit a paper for publication. When we dig deeper into that, about half of the papers that they participated in or tried to submit are case reports and cross-sectional studies, and actually case reports are not accepted as a graduation thesis for their graduation program, for their postgraduate programs. So even those participation and submissions are not very effective. However, when we asked them about the motivation to participate, they thought that this is an important skill to learn, and they wanted to relay information, and that also applies to why do they consider submitting paper for publication. When we asked those who didn't participate what was the most effective barrier for them, it was actually the lack of supervision for 40% of them, and the lack of opportunity in 36%. And now we try to test the association between the research projects they participate in and try to submit and the demographic factors. So gender and university do not affect participation or even publication of studies, but for the specialties, there is a significant difference, but in the post hoc analysis, we cannot test that, we cannot prove that any of the specialties is superior to the other specialties. When we tested against internet connection was an effective factor to make people participate and submit medical research, and that also applies to writing skills in English. Surprisingly, we have the question about source of education. A huge fraction of our participants, nearly half of them, thought that they didn't get enough training in their university or either undergraduate or after graduate. And that was actually, that has an odds ratio of 3/10, and that actually is very significant even after confirming correction. If we talk about university training, those who reported university training were not actually significantly superior to those who didn't receive any training, but those who tried to follow self-paced training were the most effective in the medical research synthesis, and that was statistically significant. Encouragement by professors was also significant, and we should note that the theoretical encouragement was not as effective as the practical support our participants received from their mentors. When we asked them what are the barriers for them to try to publish their own proposals, actually the least important factor was data collection. So more than 50% of them were able to do the data collections themselves, but less than 25% of them were able to prepare their proposals, have enough academic writing skills to prepare their manuscripts. They do not also have any knowledge about publication, publication submission, and the peer review process and the data analysis. So are we in line with other countries? No, actually the attitudes of our participants were higher than undergraduate students, and this is contradicting with other countries, and we believe that this is the reason for that was that the postgraduate students in Syria are facing a lot of limitations in their everyday work. So when they try to implement the global guidelines, they have to face a lot of limitations, and maybe that can be the reason for their higher attitudes to do research and to participate in research themselves. The unavailability of mentors was a barrier in several studies. However, it comes first for us, and it comes lower in the order in other countries. Other countries, they have lack of time, funding, reward, and even stress higher than the unavailability of research mentors. And this is actually justifiable because of the lack of mentors and equipped and experienced researchers in Syria. We can say that in Tishin University, they have higher mentors availability, and that was statistically significant. So they also had a higher attitudes toward research and higher participation rates. So this can prove the effectivity of having more effective mentors in that university. If we talk about the institutional solutions, first, the in-house workshops, those actually has been done around Syria. However, none of them targeted postgraduates in particular, and that was not very effective because postgraduates cannot attend trainings because of their time limits. So self-paced training would be the better option for them. There was a lot of options that has been recorded, posted online by SAMS in the United States, DSFG here in Germany, and a lot of massive online open courses. Those would be very effective. And these SAMS workshops were actually proved to have an effective role in raising the knowledge among their participants. In addition to that, we can suggest an online platform that gather all master and PhD projects that will facilitate collaboration between higher education students among universities and their collaboration with other researchers nationally and internationally, as well as collaborating with medical students, because those can reduce the time burden for postgraduates and create an opportunity for medical students to participate in medical research. In addition to that, allowing long-distance mentoring is very effective, and that has been proved in other countries, and that can be also a very effective solution for us. Mentors should be more active in supporting their mentees, and they should have more frequent meetings, critical revisions of each phase of the projects they are supervising, and postgraduates should get involved in more research studies before their master thesis comes. As a conclusion, even with the high attitudes we have for medical research among postgraduates, just making a medical research a requirement for graduation is not enough to enhance research productivity. So what we need is to implement more of those. As you can see, those are low cost institutional and personal efforts, and those can be very effective, as we saw in Syrian University. Thank you very much.
Thank you, Ibrahim. Really interesting topic and really problematic topic, because when we talk about publication, if we want to publish in a scientific, really well-known and trusted journal, as you've said, there is like the English language barriers. There is also, I don't know if I've missed this, but like I know that students inside Syria do have barriers to access other publications, and this is a huge barrier. So yeah, I mean, really good good point to point out, and we need also to build on this research, because like we do need to know if there is any other solutions that did not request English languages. For example, Arabic journals. Are there anything related to scientific Arabic journals? Do students have trust in those? Do they will be willing to invest time in publishing in those journals?
Yes, actually, for these language barriers, less than 35% of our participants thought that this is a barrier for them, because the barriers they face are much larger. They're not conducting research and then find the barrier just to publish like in English or in Arabic, because they can recruit other people to translate, to prepare the publication. But the most important barrier for them was that they do not have the supervision, they do not have the chance. I was a postgraduate, a physician resident there, and we do not collaborate with each other. We do not, nobody knows about the projects run in Aleppo. We can run the same project simultaneously in Aleppo and Damascus without anybody knowing that we are doing that. And then those publication, those papers do not get published, and they just stay in the libraries. And after 5 years, another person can conduct the same project. So like the barriers they face, I totally understand that language barriers and journals are very significant, but like I think that they face various more important barriers for now.
Thank you, Ibrahim, for also sharing your personal experience. For the participants and attendees, if anyone has any questions that they do have to Ibrahim, please jump in. You also can do this at the end of the session. Otherwise, I will be moving to our next speaker. Okay, so we do have Dr. Fuad. Yeah, just thanking you, and it's really a very important topic. And yeah, we can talk about it forever.
Thank you very much. Thank you, Fuad. Thank you, Hala.
Okay, so I'll move on to our next speaker, Fatima Abbas. Fatima is a graduate medical doctor from Damascus University, Syria. She is continuing clinical training in internal medicine in France, the Central Hospital of Vire, while studying for a diploma degree at the University of Paris in immunological therapies. She is an author, referee, and trainer at Koshran, collaboration and author of many research articles since her undergraduate studies. She founded an educational research project in Syria, We Research, with which she impacted the medical community in Syria by helping students learn research methodology, evidence-based medicine, and academic writing by conducting widespread interactive workshops and startups in research. Education is the main core of most of her projects in Syria, along with promoting public health and distress medicine research. Fatima will be sharing an article on the knowledge, attitudes and practices of Syrian doctors towards COVID-19 pandemic, a cross-sectional study.
Good afternoon. Do you hear me? Is my voice clear? Thank you. Thank you so much, Hala, for introducing me, and thank you all for having this very huge gathering of people who are really working on a beautiful country as ours. And I think I will share my screen right now. You can see my screen now?
Yes.
Yeah, great. I'll be talking about a small study that we have done in the beginning of the current pandemic of COVID-19 on behalf of my research team. And let's talk at the beginning about the timeline before we had the first case confirmed in Syria. We know that at the 12th of January 2019, the WHO confirmed the novel coronavirus. And until the 11th of March, we had increasingly number of cases until it was declared as a pandemic. And after that, a ministerial team approved a series of precautionary steps in Syria, including suspension of university, school, institution, non-essential public places, services, shops, cafes, Friday prayers, and all gatherings that are not essentials in Syria. And at the end, in the 22 of March, we had the first confirmed case of COVID-19. Interestingly, so late from the other countries in Syria. So why we did this study? We know that, and as mentioned in many studies earlier this morning, we have a substantial damage to the country's infrastructure and especially the healthcare forces or the healthcare system in Syria. And healthcare workers, as we all know, are key target populations of health authorities' recommendation during this pandemic. To the knowledge, to the point we did the study, there were few studies on the area of knowledge or attitudes of special groups or public groups toward the pandemic. And most of the studies done to that point were on the etiology, the symptoms, the clinical symptoms, or the genomics of the virus. As we did this study, this was the first study to investigate what we investigated, which is the attitude, the knowledge, the practice of practicing doctors, especially residents in Syria towards the pandemic of COVID-19, and the correlated factors that affected their responses to the pandemic and anticipating dealing with COVID-19 patients. What we did is a cross-sectional survey-based study between 22 and 7 April of 2020 via an online survey with information derived from the latest updates, recommendations, especially the recommendations of WHO. The questionnaire items included social demographic characteristics, question to assess participants' knowledge, perception toward the pandemic, causative agents, disease course, symptoms, modes of transmission, prevention, infection control, and available management measures. And the survey was spread via Google form through the social media platforms. As we see here, we had collected 2,060 responses from medical and paramedical participants, but we only included in this study the hospital attendings, residents, and practicing doctors in Syria, with a final sample of 806 participants. When we look at the sample characteristics and socioeconomic status, demographic data, we see that the sample were almost equally distributed between males and females. Most of the responders were under 30 years old, almost equally distributed among the academic year after graduation. But we have
German girlfriend I had, like, kind of, I'm fairly sure, like, some of her relatives who.
Excuse me, do you have any question, or do I? Okay, we have some important points that we we asked about if they were living with family or alone or with somebody else. And this is a critical point for the prevention measures, especially for doctors dealing with suspected cases. And a great part of the responses, more than 70%, were living with family or in student campuses. We asked the participants mainly about regarding their knowledge about COVID-19, about the main symptoms in suspected cases, and the diagnostic tools and preventive measures. And as we see in this chart here and the next slide, more than 90% of the sample were agreeing to the main symptoms that were known to that point of the pandemic, as we did the study. An item that we focused on in our questionnaire is their opinion about the future of this pandemic. And while more than 80% of the sample believe that COVID-19 is a serious problem, we see that 60% of them agreed to work with suspected cases or anticipated to work with COVID-19 patients, and more than 70% of them believe that we will overcome this pandemic in Syria. Also, one of the aspects that we were searching if this would correlate or would affect their responses or their attitudes is the sources of information. And surprisingly, we've seen that the most reported source of information was academic resources or published articles, with the social media in the second place, with the notion that continuous education programs, lectures conducted by their institutes were unfortunately the least reported in our sample. When investigating the correlated factors, either the demographic factors or the source of information or the gender or academic year on the responses, we didn't have a significantly statistical effect between these, all of these, with their knowledge about the pandemic. But we have seen here some items, 3 items, were correlated to this source of information, which has significantly affected the response towards the mortality rate or the symptoms of mild cases, and the academic year that affected their confidence in dealing with complicated and advanced cases. We also conducted a case-based items to investigate their practical practice attitude with a reference of the of information to that point of time, because until now we don't have certain answers to some of these. And we can see that more than 80% of this sample were agreeing with the known clinical knowledge to that time, or or believed in some treatment modalities that were suggested by many research articles, like using oxygen therapy, azithromycin, and hydroxychloroquine, for example, which was hugely discussed in many research studies at that time. So we have here 56% of this sample agreed to use this in patients with hypoxemia and shortness of breath. So we can see here that most of our responders had a positive attitude and knowledge towards the pandemic, which was almost similar to the previously studied articles or conducted articles in the similar pandemics, outbreaks, or epidemics like SARS, or the studies conducted in China to that time. Remarkably, we've talked about that the education programs in our sample played a small role in gathering information. Only 2% of the participants depend on the educational program as a source of information, which imposes a huge importance, and we think that it is related to the lack of consistency and resources in our educational system after the Syrian crisis, and especially regarding the online or the huge transformation from traditional education and online platforms that was supposed or suggested in this pandemic. Regarding the attitude, we've talked about, we've seen in our findings the positive attitude of our sample through analyzing answers to several items, like if they would agree to work with COVID-19 patients, or would they conduct elective procedures, or would they commit to the preventive measures, and how would they keep up with the information. And we've seen another point, that the academic year may be correlated with their confidence to confront complicated and more advanced cases, which is maybe related to their confronting of huge number of cases with high flow rate of patients in their centers. To mention the limitations of our study, we can say that using online method to reach our target population was one of the limitations, and yet it was a positive transformational tool to cope with the current pandemic, and because we Syrian doctors and medical students use social media as the main platform to communicate, it was a little bit of importance. Another limitation is that the information about the pandemic was being updated and changed in a short range of time, which necessitated us to do this study in a small range of time and collect data in a short period of time. And yet there is a need to recollect data about how they faced the increasing number of cases afterwards. Another limitation to mention is that we didn't included any of the isolated regions in Syria due to political difficulties, which necessitates conducting other studies in these areas. Till now, we have 5,000 cases confirmed in Syria. I think this number is estimating the current cases, but I would like to acknowledge the work of our healthcare workers in Syria who continue to serve people under excruciating circumstances, and to the health workers who we lost in Syria in this pandemic. And these are our references, and thank you.
Thank you, Fatima. Another really important topic to talk about. I do have a very quick question from one of our attendees.
Yeah.
It says, did you have an ethical approval to conduct this study from Ministry of Education or Ministry of Health? And did you publish this study in a peer-reviewed journal?
Yeah, we've got an ethical approval from Damascus University Faculty of Medicine with the supervision of Dr. Marwan Halabi, and we have submitted this paper. It's under review now in a scientific journal.
Thank you. And I'm aware of the time. I know that we will try and spare some time also to take more questions, but I'll go to our third speaker now, who will talk about zoonoses and its link to COVID-19 among Syrian refugees and host communities in Jordan. Dorien Braam has worked with government, non-profit organizations, and UN agencies across Asia, Eastern Africa, and Europe on migration, health, labor, and protection. She is currently director of the Global Research Consultancy Practice Labs and PhD candidate at the University of Cambridge, researching zoonoses in displacement in Jordan and Pakistan, funded by the Gates Cambridge Trust. Yeah, awesome. I can see
Thanks
that.
Very much.
Sharing her screen.
Thanks, Hala. I hope you can see my screen and hear me.
Yeah, all right.
Thank you so much. Thanks again for having me and giving me the opportunity to speak among such a great company of researchers that are actually in Syria and the region. So I'll be speaking on some of my work that I'm doing for my PhD in Jordan on zoonotic disease risks and vulnerabilities of Syrian refugees as well as host communities. And at the end of the presentation, I will talk a little bit about the link to COVID-19, which also caused me to cut short my field work. So it's very much a work in progress, and I would love to hear your thoughts about any forthcoming research that I could potentially carry out. So my name is Dorien Braam. I'm currently based at the Disease Dynamics Unit at the University of Cambridge. Most of you will be familiar with zoonotic diseases that are transmitted between animals and humans. And using a very conservative estimate, we believe that over 60% of emerging infectious diseases come from animals. While endemic zoonoses affect lives and livelihoods the most, especially among those livestock keeping refugees and host populations. Of course, now zoonotic are mainly in the news because of COVID-19. I'm looking at how health risks are higher during emergencies, not only because emergencies cause some of the diseases, but also because displacement exacerbates the risks due to changing pathogen and vector environments. While access to healthcare, as we heard in many presentations before today, and challenging living conditions affect disease further. So displacement also produces syndemics, and by that I mean that two or more epidemics cause disease clusters. For instance, NCDs or malnutrition increases the risk of infectious diseases, including zoonoses. So currently there are very few robust studies focusing on zoonotic disease in displacement, and even less using primary data. Meanwhile, animals often remain an afterthought in humanitarian responses, and livelihoods are thereby ignored, including the chances of people to return or to establish themselves somewhere properly. Meanwhile, however, since the conflict in Syria, we have seen an outbreak increase of leishmania, tuberculosis, and rabies, for instance, in Syria and the surrounding countries. The aim of my study is therefore to determine how displacement affects the vulnerability of refugees as well as host communities to zoonotic disease risks transmission, with the aim not to only support local and international humanitarian agency policy response and development, but also international funding, and to refocus that towards zoonoses and health. So to support my data collection and analysis, I developed a conceptual framework based on a literature review looking at disease risks during crisis and displacement, by using the eco-social theory on disease distribution, which was developed by Nancy Krieger in 1994. This theory enables me to go beyond modeling of just biological and environmental factors, and importantly take into account political and economic processes as well as socio-economic inequalities, which are very important, especially in refugee populations, and how these express themselves in health outcomes. So as you can see, the framework consists of 3 levels in 3 areas: technological, biological, and socio-political, at national, community, and household level. And some of these include, for instance, the level of stress that people have during displacement, which affects their immunity, and others, of course, are linked to policies at a much higher level. So following the outbreak of the Syrian conflict and the collapse in the health systems, the veterinary sector also lost access in terms of vaccinations and quarantine control. And an initial lapse in border control enabled smuggling of animals, which resulted in some of the outbreaks of transboundary disease in Jordan, affecting mainly the host communities at the time. I'm saying mainly the host communities because by the time Syrian refugees, initially they became internally displaced, they lost their animals due to attacks or due to theft, or they sell them as they needed cash to sort of move onward. By the time they entered Jordan, most of them would have lost their animals. So while smuggling happened, it was increasingly rare, and it was not so much the refugees who ended up in Jordan without any assets. There are several pathways to refugee status, and importantly to note is that people that ended up in Jordan, and especially the area that I'm looking at in Mafraq, usually have relatives living there, are from the same tribe, speaking the same language. So currently there are an estimated 1.1 million refugees in Jordan, of which only about 650,000 are registered with UNHCR. On the map, you can see where most of these registered refugees are located at the moment. So their access to services and livelihoods depends on their formal status, as well as living location, with 80% living outside formal camp settings. By the time people end up in urban areas, they have access to hospitals, of course, in the private and public sector, but the people in rural areas, the ones I visited, often face lack of transportation and lacking the funds to pay for transportation or actually pay for healthcare itself. Refugees struggle to obtain work permits as well, and are not allowed to own property such as livestock. In terms of healthcare, the Ministry of Health, supported by UNHCR, is responsible for initial vaccinations and health checkups, while in the camps, NGO clinics conduct health services. And some NGOs have set up urban hospitals for free for a refugee population. However, formally, refugees fall under the National Health Services, and this costs money, and it has changed a couple of times over the years how much people had to spend. Risk factors specifically affecting refugees, as I mentioned before, include trauma and stress from the conflict and the displacement itself, but also underlying conditions, living conditions, and access to information. So I conducted my fieldwork in Mafraq, roughly in the square on the map, in and around Zatri village, home to Jordan's largest Syrian refugee camp, in an environment that's very similar to that across the border in Syria. This is important to know because many of the people I interviewed used to be livestock keepers in Syria as well, and they're very familiar with the terrain. I interviewed both Syrian and Jordanian livestock owners on their living experiences, livestock, and diseases. So I'm using an embedded case study methodology, consisting of qualitative interviews, focus group discussions, as well as observations. And I try to speak to both women and men as far as they were livestock keepers or taking care of the livestock themselves. I conducted 14 expert interviews in Amman, Irbid, and Mafraq, and that was supported by 16 household level interviews, which combined Jordanian and Syrian livestock keepers or people working in the livestock products markets value chain. So as I mentioned before, there are multiple pathways for refugees in Jordan. Most people have passed through Zaatari camp or one of the other camps right after entering Jordan. But then most of them end up establishing themselves in so-called urban areas, which includes Zaatari village itself, which you can see in these pictures. In the background, you can see Zaatari refugee camp, and this is where the village starts. People either rent shelter and rebuild their livelihood. So slowly they start buying some animals and breeding with them. And if they keep their animals, they're generally kept in the same compounds where they live. So that increases their risk of zoonotic disease. Meanwhile, they are often dependent on relatives and connections in the host communities for agriculture, fodder growing, as well as other services. The second pathway are seasonal migrants, which remained in Jordan after the start of the conflict. So they now live permanently in shelters that were actually meant to be occupied only seasonally, herding animals for Syrian owners or keeping small livestock in informal tented settlements while working at Jordanian agricultural farms. Yet another pathway is the Bedouin, which have become displaced in a completely different way. So they became unable to move around with their animals and are forced to sedentarization. As Syrians are not allowed to own animals or property in Jordan, they are dependent on relatives or pre-existing connections for their assets registration, if they even try to make that happen, and thereby increasing their socioeconomic risk. They are potentially at risk of losing everything. So to summarize some of these initial findings, the pathway of a refugee influences their living environment as well as formal status. And that is in turn determines their access to services, including veterinary care. Without being able to own the animals and register the animals, they cannot access veterinary public services such as vaccinations and other disease control mechanisms. While using pre-existing networks for livelihood, shelter, and services, animal registration and veterinary care are therefore dependent on even knowing someone and getting someone to register these animals. Alternatively, if they can't do that, then they need funds to access the private sector. So, zoonotic disease risks specifically increase the risks in displacement when there is more animal to human interaction. This includes occupational hazards, as you saw before, with people living in close proximity in informal shelters. And these risks are further exacerbated by malnutrition, etc. So these complex interactions depend on the context and are individual, although all are influenced by the power and poverty dynamics, which depend on policies and institutional responses. The refugees mentioned quite often that they were suffering from non-communicable diseases, which often remained untreated, which due to a lack of information and access to healthcare affects their immunity to further infectious diseases. Including zoonotic diseases. And of course, this is something that we've seen globally with COVID as well, where people with underlying conditions are much more at risk. So refugees are not only more susceptible to their pre-existing conditions, but also the pandemic further limited their access to services because of the movement restrictions, which were implemented quite quickly in Jordan. As well as the closure of refugee registration, which happens, which was temporary, but it remains closed for a couple of months. The pandemic, however, does also provide some interesting opportunities because all of a sudden it seems to be possible for UNHCR to provide mobile services. So they come by with medication, they provide mobile cash points where refugees can pick up their money to buy food and everything. And this sort of slowly increases the refugees' agency itself, and hopefully these are possible to remain with proper investments. So, as I mentioned before, it's still very much a work in progress, but to have some sort of initial conclusion, I would like to say that zoonotic disease risk levels depend on formal status primarily, and thereby their access of the access of refugees to health and veterinary services. And this requires not only a veterinary public health response, but importantly, a transdisciplinary multi-level approach to disease and underlying risk factors. So for a comprehensive response, legal frameworks as well as services need to be more inclusive, while local solutions should be prioritized to support refugees and host agency. And I would like to acknowledge my team in Cambridge, but more importantly, the Syrian and Jordanian respondents who so kindly volunteered all this information, especially also thanks to Sammy from the IFED, who hosted me in Mafraq and who can unfortunately not join us here today. Thank you so much.